started.
Thanks, Sue. So questions can be asked at the end of the session via the chat function, which you'll see there's a button called chat, and you'll see things appearing in there throughout. However, if we run out of time, then please send your questions to the email address that you used to get the invite, which is membership@swift.nhs.uk, and we'll endeavour to get answers back to you, and we'll share those with everyone, obviously. You can also use that email address to request a copy of the presentation slides, and we're doing it that way so that we know how many people were actually interested in and wanted to receive them, rather than just spam everyone who got it first time. So I'd like to introduce Dr. Bhaskar Varadarajan, consultant in diabetes and endocrinology, and also Duncan Vernon, who's our consultant in public health. And I'm going to ask Duncan to start the presentation, and I will mute myself and disappear.
Excellent, thank you. Thank you for the introduction, Mike, and I'm looking forward to talking to you all, and thank you for joining the call. In a bit, I'll pass over to Bhaskar, but to talk through his slides. But I was going to briefly talk about prevention, what our role is in preventing ill health as a trust, and also talk a little bit about the opportunities for preventing future cases of type 2 diabetes as well. I'll talk a little bit about the health in Warwickshire overall to be able to frame that before passing over to Bhaskar for some of the latest innovations and sort of techniques around treatment and the why, the what, what's new, and what we can all do. Finally, there's a Q&A session at the end. So I mentioned in terms of what we're trying to do as Swift and as a trust, and there's a big commitment now in our new trust strategy to embed prevention in every service. I think we recognise the challenges of further demand and need amongst patients and amongst the population, or need for healthcare services. And actually, what are the opportunities that we can do to take to support people to live healthier for longer, so that actually people are using healthcare services less and able to live healthy and fulfilling lives. This is why, one of our big moves as a trust is to embed prevention in every service, and that applies to diabetes as much as any other health condition as well. If we move on to the next slide, Bhaskar. So why prevention? I mean, there's a lot of rationales given why. And I think this is one of the critical ones for me. It's about actually, our population is changing, and the demographics of people living in Warwickshire as a whole is changing as well. And actually, some of these trends are more pronounced in South Warwickshire as a whole. But essentially, this is what I would call a population pyramid. You can see down the left-hand side, we've got different age bands. You can see, for example, split up into 0 to 4, 5 to 9, and similar, all the way up to numbers of people aged 90 plus. On the left-hand side of the central column, we've got men, and on the right-hand side, we've got women. And essentially, the aim is, the bigger the bar, the more people there are in that population. So you can see as well the outlines from 2011, and then the solid colour bars of 2021. What you can see here is actually there is a solid coloured bar between 50 and 59, and that's what we're saying in terms of an increasingly elderly population. You can see, and over the next 20 years, you'll see that bar moving up, and actually more people in that population group needing healthcare services. Ditto, you can see some population growth, particularly in sort of 70 to 79, when health in particular becomes worse. So there's typically for people in Warwickshire. So if you remember that age, what I'm basically saying from this graph is that there's a large number of people aged between 50 and 59 at the moment, and are likely to, will be getting older. If we move on to the next graph, remember those ages, you can see here what our estimates are for healthy life expectancy and life expectancy in Warwickshire. So life expectancy is, as you would imagine, the average age at which someone born in Warwickshire can expect to live to. Healthy life expectancy is therefore the average age at which someone can expect to live in good health. The difference between the two is typically when there is a window of need, when people are relying on healthcare systems more, when people are relying on things such as adult social care, and when there's the need to support people to sort of navigate the healthcare system and similar. I mentioned we have a large population aged 50 to 59, and you can start to see there the healthy life expectancies are around 64 to 62. So therefore, a large proportion of people in that bulge within our population are likely to tip over into poor health in the next 10 years. So this is why prevention is important. And actually, we've seen over the last 20 years, life expectancy improvements have stalled. There's often been since the Second World War, there's been a large improvement in life expectancies. But you can see, therefore, if you start to plot this over the last, you can see over the last 10 years, that rate of improvement has slowed down significantly. So actually, not only is there this window of need, but actually there are more opportunities to improve health and well-being that we could be taking. Move on to the next slide. When we're thinking about health and well-being and prevention, I often like to talk about this. And this is what we call the Kingsfund model of health and well-being. It was developed by the sort of healthcare charity think tank, the Kingsfund. And essentially what it does is describe the things that cause ill health. So when I say people tip over into being unhealthy, what are the things that influence that? And actually, it's not just the health and care system. There's a lot more of that does influence our health and well-being. And these are the four quadrants of this graph. So you can see in the bottom left, yes, you need a health and care system in order to support people to remain healthy in terms of preventative services like vaccinations and screening, but also in terms of being able to support people when people develop a long-term condition. In the top left, you've got the wider determinants of health and well-being, and that's what I would call the causes of ill health. Those are things such as how your income can protect your good health and support your life and support you to sort of live a healthy and fulfilling life. Things such as education, which in the early years pretty much set the course of your life, and things such as the quality of the housing that you live in and how you're able to travel around Warwickshire. Are you able to cycle or walk, for example, to your local shops, or do you need to drive? There's things such as health behaviours and lifestyle, and actually a lot of these are very pertinent when we talk about diabetes. I mean things such as here is physical activity, smoking, diet, your sort of traditional health behaviours, and I'll come to talk about obesity in Warwickshire in a minute. And then finally, in the bottom right, we're increasingly understanding this relationship between our mental health and our mental well-being and our physical health. So the number of people who you are in contact with, the social support networks that you have in the community are important to your well-being. And actually you find that when people are socially isolated or lonely, but things such as hospital attendances increase, risk of developing long-term conditions and frailty also increase. So again, this is that strong relationship between our mental well-being and our physical health. If we go to the next slide. I also think, as well as those four quadrants, when we talk about prevention, we can think about different opportunities for prevention. So it's not just about, yes, it is about stopping people from smoking and supporting people to eat more healthily and to be physically active and similar. And those will prevent a disease before it occurs. But then also we can do work within the health and care system and within our trust to identify things that have already occurred but not been detected. So this is sort of early diagnosis and opportunities to access screening, as well as tertiary prevention. So actually, once we've diagnosed something, how do you support people to live with a condition? So all of these very relevant for diabetes, and using this to say, actually, it's not just about the upstream stuff and preventing ill health. There's more we can do further downstream as well to support people as they develop long-term conditions. I was going to talk about diabetes and some of the stats, and I've got some Warwickshire specific ones fairly soon, but just to give you that UK-wide estimate, across England, across the UK, 4.7 million people currently living with diabetes. And you can see some of the estimates that this is continuing to increase. So you can see the trend there. By 2025, it'll be 5 million. By 2030, we estimate 5.5 million. And the bulk of those are people living with type 2 diabetes. So this point about the number of people with diabetes is increasing. So actually, when we're talking about prevention, this is a critical condition that we want to be focusing on. And also we know the risk factors and we know what causes it. And I'll talk through some of these in a bit of detail, but we can see here that obesity is the leading risk factor and the leading cause of diabetes. On a population level, if you're obese or overweight, it increases your likelihood of going on to develop type 2 diabetes. And you can see here the statistic, it's responsible for 80 to 85% of that risk. So it is the key risk factor. There are others which I'll come to in a second as well. This is my point about that increasing rise of prevalence of diabetes and the number of people who are living with it. And you can see here data going back to 2009-10 financial year, all the way up to our most recent, which is the 22-23 financial year at the right-hand side of this graph. You can see the percentage down the side, and you can see that actually it's gone up from around 5.5% to around sort of just over 10 years later, increased to just over 7.5% in England. So you can see actually this is a relatively quick increase, what we're seeing in the number of people living with diabetes. The line underneath is the number of people living in Coventry and Warwickshire. Unfortunately, I don't have further breakdowns. I could tell you a long story about how we're reworking out our population estimates based on the new census data. But for this stage, I'll probably just say, what you can see is the general trend is the same as England. It is slightly lower in terms of our percentage, but it's the same direction of travel. So it's only 1 or 2 years behind that England rate. And we can see here that driving factor behind it. And this is something that has increased dramatically, the prevalence of adult obesity. I have similar graphs for childhood obesity, of course, and similar graphs for childhood obesity in Warwickshire. But you can see here that for both men and women, the prevalence of obesity has risen and risen quite dramatically. For women, for example, we have the percentage down the side, and it's just from about 17% in 1994 to around it's 30%. And that was a couple of years ago. This is based on a health survey for England. You can see a similar rise for men as well. And actually, this is caused by, I mentioned those 4 quadrants. Each of those has a role to play in that, in terms of supporting patients and supporting people who are living with obesity to lose weight, and through our health and care system, looking at how the environment makes it easy to access unhealthy food and unhealthy food for cheap. The social support, sort of not being there to encourage sort of healthy eating and similar, but all of that we see in the this rise in obesity. Another risk factor is, of course, deprivation. So where you live impacts on your likelihood of having living with obesity. And again, what we see here is essentially for men and women living in the least deprived to the most deprived. So the most affluent areas in our country, in England, are on the left-hand side, and on the right-hand side is most deprived 20% of areas. You can see here how obesity prevalence varies quite dramatically. So there's a 10% difference amongst men. So you can see actually that change in most affluent of about 22% to about 30% in the most deprived areas. Ditto, you can start to see a large increase there for women as well living with obesity. So again, inequalities influences your likelihood of getting type 2 diabetes, and often we see a much earlier onset in more deprived areas. If we can go to the next slide. I also just wanted to mention as well, there are other factors such as genetic factors, and ethnicity plays a role here as well. We see the increased risk, for example, in our South Asian population in the UK, and also people of African and African Caribbean descent as well are also more likely to develop type 2 diabetes if everything else is on a like-for-like basis. So again, you can start to see other factors influencing this. I think that's my section, and I'm going to pass over now to Bhaskar. So it's over to you.
Thank you. Thanks, Duncan. So I often joke saying that I probably chose the right field. With that kind of rate, certainly I'm in my job until AI comes and swallows me up. Maybe not in my generation yet. But I think the truth is, with the rise in diabetes and obesity, we all see it, that the cost to NHS is actually steeply rising, and steeply rising still. And if you take into account that on an average, our population, we are about 4 or 5% with diabetes, and yet NHS is spending double the money for the population that it's catering to. So it's an expensive condition, because a lot of, even if diabetes is not the reason for admission, a lot of hospital stay and delays in hospital journey are contributed by diabetes. But the key point you need to remember, and again in line with the prevention strategy that we're talking about, is the vast majority of money that is plowed in for diabetes care is actually dealing with the complications of it. So while we all want to, of course, prevent diabetes and make me jobless, and I'll be delighted if we get to that point, we, of course, second best would be to say, okay, we've had it. What can we do to mitigate it becoming a threat, becoming a complication, so that I can bridge that gap between the unhealthy last 15, 20 years of my life and narrow that towards a much healthier finish towards the end. So preventing complication will not only be health saving, it will be financially hugely saving too. So this is the first bit of clinical slide I want you to take home, and I will come to take home message 1. So when I talk of complications with diabetes, and we get a little too hooked up about the blood sugar value, this and that, but the bottom line is, what does a label of type 2 diabetes mean to someone? The truth is, and here it starts with 40, and now dare I say I need to draw this figure all the way to 20. Adolescents are developing type 2. When I was in medical school, type 2 was a 50 plus diagnosis. Now it's already coming to teens and 20s thanks to the era we are living in. But regardless, the key message you'll have to see here is a person at the age of 40, for example, with a label of diabetes is at risk of losing about 6 to 7 years of his lifespan, and of course a bit more for a woman. So having a label of diabetes means they have sliced off average of 7 years of their lifespan that they would have otherwise been entitled to. And you can see, of course, as the diagnosis age gets further up, age becomes a much more compelling risk factor, and therefore the loss of lifespan is naturally smaller. So in my mind, I am seriously worried of my 20s and 30s and lately teenagers who are developing diabetes, because if I was to draw this graph further up, they probably are at risk of losing at least 10 years of their lifespan. And this is death. We're not talking about the quality of life and the unhealthy phase of their life. So it worries me, and it is important that people with diabetes acknowledge that having that label actually literally cost them some years of life, both in quantity and definitely in quality. And this, like I said, does diminish with age, not because diabetes becomes less potent. It's just that age becomes a far better potent risk factor for cardiovascular disease. And this majority of this lifespan lost is actually on CVD, which is otherwise called cardiovascular disease, which is a constellation of strokes, heart attacks, and peripheral vascular disease, as in gangrene and circulatory problems. And the mortality risk with diabetes is at least 2-3-fold. And if I drew this graph 20 years ago, before the statins and aspirins and all those modern evidences that have grown with my evolution as a doctor, we were talking 10, 12, 15 years of lifespan lost. So medical advancements have definitely bridged this, but I would be lying if I said even today, a younger onset diabetic, and everybody actually stands to lose some of their lifespan as well as healthy component of their lifespan. So the first, and of course, the other reassuring factor is actually, this is such an interesting study that I thought is worth sharing with public. And this also showed to me that if you want to get a great publication in the best journal in the world, which is the New England Journal, you only needed 160 participants. This is our Danish colleagues called the Steno Center who did this study, where they put 80 people through intensive treatment of their blood pressure, cholesterol, sugar, weight, smoking, the very things that these days you would expect us to do in your diabetic consultation, and put the other 50%, 80 individuals, through conventional care. So they were told what to do, but nothing was invested extra in terms of hammering them down to very tight blood pressure or very tight cholesterol or aggressive attempt at getting their cigarettes out or getting them to lose weight, etc. What did they find? Over the 8 years of study and the subsequent 5 years, even after the study completed, the ones who had intensive treatment, which is the blue, started having much lower risk of death. This is real death. We're talking death here. So people at diagnosis subjected to intensive treatment stood to gain at least a 30, 40%, 50% chance actually of not losing their life earlier compared to conventional treatment. And the same gap was prevalent with living with cardiovascular disease like a heart attack or a stroke. So what this study told us, along with the previous study, is cardiovascular disease risk is very high and some of that risk can be mitigated. At least half of that risk can be mitigated. And that mitigation is not just about controlling sugar, it's what is called as the multifactorial intervention of aggressive treatment of glucose, blood pressure, cholesterol, urine protein, as well as all the lifestyle behavioral changes that we expect of people with diabetes. So there's a bit of bad news that having diabetes is not great, but there is a bit of hope that actually there is things that we can collectively do to mitigate that risk. Not neutralize, I'll be lying if I said we could, but we certainly can mitigate it. And this is why, and this is my colleague from Nuneaton who created this alphabet strategy, that when you may or may not have seen it as A to G, but whenever you have your diabetes consultations, be it with your practice nurse or the specialist nurse or the dietitian, we are interested in all of these components. How do we get the lifestyle advice? How do we get the blood pressure tight? How do we make sure that you're on the best statin dose that can bring the cholesterol down? How do we also focus? You will see that there was a time when I took diabetes, they all kind of thought that I was a sugar doctor. And we are now increasingly saying sugar is just a component. It's really, we are the medical cardiologists. I often say that because the cardiologists have gone ahead, started plumbing and putting stents into blocks. So we live with the medical cardiology of the world is us, because we continue to occupy the bulk of our cardiac units and stroke units. Even though as a population, diabetes is only 7%, you go to any coronary unit or a stroke unit, a third of patients, if not more, have diabetes. So cardiovascular disease management is part and parcel of diabetes care. So the first take-home message I want you to remember is on the back of Duncan's data, age, diabetes, and obesity is on the rise. We can't shy away from that. The second message I want you to remember is diabetes equal to early cardiovascular disease. And don't get me wrong, you don't need to have diabetes to have a stroke or a heart attack or a gangrene, but having diabetes doubles, if not more, that risk. And on the positive front, this risk can be reduced to a sizable extent, but requires a lot of concerted effort from both parties. I say both, multiple parties, but patient being the key important person in the middle. And that focus is not just about glucose. That's the third take-home message. And I did promise when Sue asked me, what are you going to talk about? I said, okay, let me share a few developments within diabetes. So I bet some of you have tied up to say, what the hell is new about diabetes? I know all of this already. So I thought I'll share one or two newer developments that might certainly excites me and hopefully will excite you and the future generations, because we are starting to see more and more investments to try and reduce that risk. The first thing I will say, again, on the scheme of prevention, is we talk about preventing diabetes, and that's known. You lead a healthy lifestyle, eat less, do more. That's as simple as that. And keep your weight under check. I can't change my age. I can't change my genetic origin. I can't change my family history. But I am left with a few things that I could influence, and those are the bits that I should be putting my efforts on. But then this study, which is actually a homegrown Glaswegian study, that picked up people with diabetes. So we're not talking no diabetes to preventing diabetes. These are people who develop diabetes. And this is one of actually a powerful study in my mind that is bringing me to change the way I consult with people with diabetes. I no longer talk about control. I sincerely want to raise the word cure. I sincerely want to raise the word, you can push this into remission. You can cure. And that personally is a much better motivator than saying, take this extra pill, let's try and contain the problem. And why do I say that? because this study actually changed the way I approach type 2 diabetes. And I think it's going to change the way we are approaching as a population, how to tackle, especially the ones that I told you, which is that young onset. That seriously is a concern for me when a 20-year-old and an 18-year-old and a 25-year-old develops a label of type 2, because that only 20 years ago would have been unheard of and now becoming a little more common to everybody's liking. So what does direct studies show? What they did was subjected a cohort of patients in primary care. So this is not Steno, this is not Denmark, sophisticated tertiary center, primary care. What did they do? Of course, they went ahead and said, and these are people who all had diabetes on an average for about 6 years, and they were all on tablets. They subjected them for a period of 3 months where they decided to stop all their diabetic treatment and blood pressure treatment and say go on food replacement for a period of 3 months. And I'm not for a minute recommending that we have to do, but you will see on the data that it shows on why I am sharing this data. So what they did was put them through a 3-month period where they replaced food with soups or various formula feed that allowed them to survive on 850 equivalent calories per day over 3 separate food. And then after 3 months, they were asked to reintroduce food as they chose to. And then they looked at what happened to their weight and their diabetes, bearing in mind they were all diabetic to start with, and they all had their treatment withdrawn to put them through to this trial. And over 24 months, they wanted to see what it actually meant to the diagnosis. What did they find? At the end of 12 months, 46%, nearly half of all patients who all had diabetes had their diabetes cured. Okay, cure 12 months, meaningful. Is that enough? We'll see. And then they shared more recently the 2-year data where it said 1 in 3 who went through that program still stayed without the label of diabetes. So for the first time at a primary care level, in an early onset, and I say early as in within the first 5 to 10 years of a label of diabetes, putting them through an intensive period of diet restriction and supervision with dietitian and smoking advice and what sorts could show that 1 in 3 could stay without diabetes for at least 2 years, and they are continuing to build their data. So very soon we will get their 5-year outcomes. And more important is if people lost more than 15 kilos in weight, because they did have selection of people who lost 5%, 10%, some lost 15%, but the magic number was 15 kilo or more weight loss. Nearly 3/4 of them stayed away from having the diabetes come back, at least for 2 years. Admittedly, you can call this a delay because I can't say cure until the long-term data comes, but this gave us insight to the fact that even after getting a label of diabetes, it is not too late to try and reverse that natural history. And the bulk clue, going by the fact that obesity part and parcel leads this epidemic, is weight loss. And the magic weight loss is 15, but even 10 kilo weight loss, there was sizable response. So the second take home message I want you to take for you or for your family or for your friends is type 2 diabetes need not be a permanent label. Second, losing weight can mean losing diabetes. And the magic number is 15 kilo, but every little helps in this instance. I don't know if it's Asda or Tesco who says that, but it doesn't matter. And weight loss, admittedly, is not easy, but not impossible either. We all know that because we've all done that periodically. Of course we do. Only it's not lasting. What else is new? So I think that's the second take home is you don't need to have a permanent label necessarily. There is always scope to reverse. Yes, admittedly at the earliest stage. And I say early, up to 10 years of label of diabetes. What else is new? I wanted to introduce a little bit of new knowledge on how diabetes therapy has moved on. When I used to be a trainee, there was all of metformin, gliclazide, insulin. End of story. Diabetes management was dead easy. It's one of these three in whichever order. Almost everybody ended up on all of them. Thank you very much. And we were actually focusing a lot on liver and pancreas. So we felt that diabetes was a pancreatic problem. Of course, lack of insulin must be the reason for the sugar. But then we forgot that there were 2 or 3 other organs that may contribute to diabetes. And one of that was this effect. And I'm sorry if it is an overwhelmingly medical slide, but I wanted to convey this fact that there is an effect called incretin effect, which is the intestinal contribution to the way you and I handle our glucose load. And this is a clue. Whenever you see a study that says healthy volunteers, you read that as medical students. Bless them. We have no choice but to rope them into all these healthy volunteer trials. So these trials looked at 8 people and kept their blood glucose in a controlled environment over a 4-hour period. Just to share with you that, and the yellow arm and the blue arm are the same 8 students, one day with oral glucose, that's the yellow, and one day with intravenous glucose to keep the same blood glucose. And yet, when they check their insulin levels in the system for the same amount of blood glucose, and we measure C-peptide as a surrogate because for every time we produce insulin, we measure the same C-peptide. And what they found is even though these 2 sets of individuals, which is the same set on 2 different days, had exactly the same blood glucose, the amount of insulin they produced was far higher when the glucose was in the gut. In other words, the intestine seems to send another powerful message to the pancreas to produce more insulin than just glucose in the blood. So what that told us is we're missing a trick with controlling sugar just by dealing with the pancreas, by either releasing more insulin or making your insulin more effective by giving metformin and other sensitizers. So this opened up a new channel of treatment that essentially was mediated by a hormone called GLP, which is an intestinal hormone. And what you now know is almost every pharmaceutical company, obviously, they want a share of this diabetes market because you know from Duncan that this market is growing and this market is pretty expensive to treat. Everybody wants a bite of that cherry. But hey, I'm not being critical here, but this has meant that the intestinal component of our glucose handling, which was overlooked, and by the way, that study that I showed you was done in the 70s. People kind of forgot about it, and then it somehow serendipitously got revived. And people have now created a GLP like injections. And almost every company is making one now and started off as twice daily to once daily. And some of you may already be taking it, and some of you may even know others who are taking it. We are moving into weekly injections. Why are they important? Because this is a novel mechanism to target glucose that we didn't tap 15 years ago. And because it's novel and it also such a powerful mechanism because you can see the amount of insulin your body can produce through this mechanism. We're starting to see far more potent improvement in control. We are starting to delay insulin for a lot of patients. Like I said, 20 years ago, it will be metformin, gliclazide, insulin, all within 2-3 year period. And then it's all about fiddling the insulin doses to keep the sugar reasonable. But now with this avenue of a gut hormone supplement called GLP, we are able to potently bring sugar down. And for the first time, I should say, we're also promoting weight loss as a great side effect because this is a far more physiological way to handle glucose. The next mechanism, and I was one of those trainee registrars when those marketing surveys happened. What do you think about flogging the kidney to push our glucose out? And we all laughed off and said, because we've grown up in diabetes clinic telling patients off for having too much glucose in the urine as a measure of poor control. But then it dawned on us, why can't we turn that tap on, release that extra glucose through the urine and bring your blood glucose down? And honestly, I tell my medical students, never shun any idea. This is one good example of that, because what is typically your natural effect, which is filter all the glucose into the kidney, but then the urine reabsorbs all of it back because we can't afford to not have glucose in the system. But then pharmaceutical industry worked out that you can block this reabsorption using the sodium glucose transport inhibitor. What did that do? It allowed that excess glucose to get off into the urine. And each glucose is what calories is. And on an average, we lose about 4 calories if you lose a gram of glucose a day. And as long as your kidneys are functioning okay, you can get 80 grams of glucose out through the urine, which then means almost 320 calories of energy deficit, which is half a stone weight loss over a period of 6 months. So this has also opened up another channel which we didn't exploit before. This is not working on pancreas. This is not working on liver. This is not working on the muscle. It's simply turning the tap and pushing the extra glucose out. And the advantage, like I said, is calorie deficit, which meant a degree of weight loss. And the other advantages we are now seeing, and by the way, this is the data that will show you how potent these new treatments are. And I've got all those SGLT, which is that urinating tablet, and these injections of GLP. You can see that they're so potent that in all currency, the HbA1c of 1.5% is now pushed. So these new therapies are proving far more effective in bringing glucose down. And importantly, it's starting to push people to lose weight. And I told you the magic number is 10 kilo or more of weight loss. And now we have novel medical therapies to allow us to exploit that weight loss alongside. And I must stress, these are not substitute for your effort, but it does make our efforts far more rewarding. So these newer therapies have certainly opened up a line of thinking that allowed us to delay insulin, that allowed us to meaningfully not only improve your sugars, but actually facilitate some weight loss, which we keep going back to either as a chicken or an egg as a contributing factor to both onset of diabetes and progression of diabetes. Not only that, if I take you back to the fact that diabetes equals cardiovascular disease, who cares if I bring sugar down if I can't make them live longer, which is what our bulk of the aim is. These newer therapies, and again, apologies for giving you some medical data, but by now you've already sensed that if the graphs are separating and if the intervention arm is down, it must be doing some good. So compared to placebo, where they go through exactly the same treatment, but not these newer therapies, the newer therapies are meaningfully reducing risk of heart disease and death. And primary outcome here refers to coronary heart attacks, stroke, or peripheral gangrene, both with the tablet as well as those injections I talked about. So take home message 3 from me is newer therapies are definitely far more promising with weight loss. They're also low hypoglycemia risk. I didn't talk about that. And they are reasonably well tolerated, and increasingly and reassuringly, they're also meaningfully improving the cardiovascular risk. And guidelines, it's no surprise, are now pushing these newer agents higher up the pecking order. Metformin, and then you go for those urinating SGLT inhibitors. And of course, subject to the weight and the BMI and the urgency, we have access to those weight loss injections. But don't quote me. Of course, the whole world is exploiting these injections, as you would have seen, and that's left us with some stock issues internationally. But we still are trying our best to preserve it for the diabetes world. But that's for another day's debate, because obesity market is now coming into the GLP class to exploit, and very powerful data that supports it. But that does mean that the companies have to get their act together to get these injections produced far more faster than they are. And I think it's an important reassurance to people who are on insulin that they don't take this as a failure of care, because the truth is, again, I didn't share the data, diabetes by definition is a progressive condition, and requiring insulin need not always be seen as a failure of care. It's important you remember that. What else can we all do? I'm mindful we have 20 minutes, so I'll try and rush through these, which will be teaching grannies sucking eggs, because you will know this already. You're not alone. That's the first message. You have a wide variety of people. And of course, Duncan already told us in the wider determinants that your family, your society, everybody has a role to play. But don't forget that you're not alone. We are here to support, and you have a wide network. But equally, I also say that at best, you get access to us 3 hours in a year. So the remaining 8,757 hours of the year, you're on your own. What does that tell you? It tells you that don't trust us entirely. You become an expert patient in its own right. And we offer a lot of diabetes courses And I will be honest, that's one of the poorest uptake, not just here, nationally. For some reason, we are reluctant to invest our time and energy in knowing how to deal with diabetes. Or if we did, admittedly, we all have such poor memory, me included, that it's never too late to refresh our knowledge, especially as the knowledge evolves as rapidly as it is. So my first or the fourth take home or 24th take home point is please be an expert patient yourself. Don't just rely on the healthcare provision because you are the one who has to manage it for the vast majority of time, albeit with access to us. Eating healthy, I think till the dogs come home or cats come home, I don't know. We can talk about what to eat, what not to eat. Simple rule, eat less, do more. And healthy eating, you have plenty of reasons. We are in an information access era. Everybody knows what to do. It's just about how do we do it and how do we do it sustainably. And we will share these slides for you to refer to if you really think it is of use, but some simple tips on healthy eating. It's all about portion control as much as all those quality data, because I've had patients say, should I have this bread or that bread? And I remind myself that eating a lot of healthy food is probably more unhealthy. So it's not just about what is good, what is bad. It's about what is that I need. And portion control in my mind is most critical. Exercise, we know exercise is great. And we know, of course, as we get older, and even I will say that because my joints are starting to creak too, that we all have some limitations in what we can do. And I often say, what is that you can do? Try and do more of it. And majority of times, you're far more likely to do something if you also like doing it. So build it as part of something that you would do anyway. Build it as part of something you like, be it walking, be it gardening, be it swimming, be it dancing, be it cycling. Any activity has to be better than no activity. And don't go mad, of course. Be gentle, but surely we can all find half an hour worth in a day to do something physical. And believe me, the majority of my referrals are patients who have failed 2 agents, 3 agents, come for insulin or not. And often just the threat of insulin, I use the word threat very carefully because it's not really a threat. I love insulin. Just the threat of insulin gets people to dip into their reserve, both with diet and activity. And how many patients have managed to reverse the journey and delay the insulin even more? So it tells us that we all have scope to improve our lifestyle at any stage of our life. And I'll be the first to put my hand up on that. So whatever reserve there is, let's exploit it, is the 25th take-home message. Fitter Futures, some of you may be aware, this is what the Warwickshire Council offers, and everybody can access that if you Google Fitter Futures Warwickshire. Within that, and having diabetes and having pre-diabetes already qualifies you. They build NHS health checks, active stop smoking advice, physical activity offers, either discounted membership in clubs, as well as 12 weeks of Slimming World, or I don't know if it's Weight Watchers or Slimming World, but one of them. So essentially, there is council offers as well that complements, but I will be lying if I said that it's this or that. It's about what you can do and what else we can bolt on with it to try and mitigate this journey which is going that way and pull them back. Standards of care. You should also know that you're entitled to a minimum standard of care at diagnosis, when you start insulin, and at least annually. And in annually, you will all, yeah, that's at diagnosis. Annually, you will all be having access to weight, urine test, blood test. We need all of that because remember that Denmark study, which looked at multifactorial intervention. And one of the problems we also face is it's so easy to get an MRI scan these days, but I can't get a urine sample of a patient to know what their protein is. Of course, I'm not blaming you, but it tells us something of the fact that we're not able to capture the risk. And if I don't know what the risk is, what chance do I have to mitigate it with you? So I think it will be very helpful if people are aware that as part of the diabetes care, even after getting diagnosis, even after being on multiple agents, that there are things that you can do and you can do to us together to help each other and help you mostly in retarding that journey towards that higher cardiovascular risk. And my pet, because I do foot care for my day job 1 day a week, is look after your feet. Because people with diabetes, by definition, lose their sensations. And as you get older, as you get a little stiffer, you can't even reach your feet, can't see it. But make it a habit to check your feet daily. Treat any minor injuries seriously. Never walk barefoot. Always wear an appropriate footwear. And like I said, this is not the be all of everything about diabetes, but I wanted to convey as much as I can by finishing off with this take home message 4, which is be aware that you are entitled to a minimum standard of care. And like I already told you, you become an expert patient, come prepared, make us work harder for you because we are here to serve you. Become an expert patient, healthy lifestyle. It's never too late. I think that's where we stop the presentation. Mike, I'll hand over to you to oversee the questions.
Thanks, Bhaskar and Duncan. Personally, I found that very educational. I really like that. What's happening out in the public structure with the clinical stuff and the individual take-home messages. So Sue is going to be the magic voice that reads out any questions which appear in the chat room, and there is a call for more info there at the moment. Sue, do you want to read that out, or do you want me to do it?
Yes, I can do that, Mike. So it's not a question, it's a comment from Francis. More information and support is needed, please, for lean pre-diabetics who have no excess weight to lose.
That's a great question. Indeed. And like I said, obesity and diabetes, we oversimplify it, and it's far more complicated than that in terms of ascribing cause. And I know, having practiced in the Far East before, that diabetes is a different beast and different ethnic origin. So in India, for example, you have 15% diabetes prevalence, and they don't particularly have massive obesity because the BMI doesn't quite reflect your diabetes risk. Actually, increasingly we're moving away from BMI. It sounds, of course, very simplistic to categorize people as obese and not obese, but increasingly we're moving away from BMI to waist circumference. So even amongst the lean diabetics or lean pre-diabetics, it will turn out to be the fat within the liver, fat within the muscle, fat subcutaneous is probably the cosmetically ugly one. It's actually not the most pathological fat. It's the fat in the liver and muscle. So even amongst lean diabetics, it's the visceral fat, as in the liver and muscle, that ends up contributing to a degree of insulin resistance. So I agree, but the truth is, even they stand to gain losing their visceral fats, even if their whole body mass index need not change. It's about burning that liver fat in favor of muscle or any other form of energy storage. So I agree with you. It's not completely about weight and BMI. There is genetics, which is of course unchangeable, but visceral fat, regardless of BMI, is also true. So abdominal circumference is a much better marker. And if in fact, some studies will say that liver fat content is actually far more sensitive as a marker of diabetes risk. But good point. I don't have a straight answer to that, except to acknowledge that that's important.
And Francis added, any chance of research on that point?
I'm pretty sure people are actively researching, but I'm happy to look into to see if there is anything that we can ourselves sign up to, because it sounds like there will be a few patients who might be interested in participating. I will definitely take that to my research associate chief officer. Thank you.
Thank you, Bhaskar. Another question from David Limmer. I am a lean diabetic on 2 types of insulin. Sorry, just bear with me. I'm classified as a type 2 diabetic. Will I become type 1 over time? I believe I am more type 1 than 2.
That's again a very, very good question. Okay, so traditionally, type 1 and type 2 were categorically split as this is autoimmune diabetes where your pancreas is failing and can't make insulin, therefore you're type 1, and type 2 where the problem is not making insulin. In fact, you have resistance to insulin. But this black and white bifurcation is actually getting far more blurred, because when the whole world is becoming obese, there's no stopping even type 1 diabetics becoming obese. So I could argue that people with type 1 diabetes, and not every type 1 is lean, nor is every type 2 obese, by the way, like you've already referred to. So increasingly, we're starting to recognize that some patients have double diabetes, as in they were type 2, but they also have, and dare I say, COVID has also started to unblock a new type of autoimmune like diabetes, like type 1 in some ways. So there's nothing stopping a type 2 diabetic patient develop the very virus that provokes the type 1 diabetes in normal type 1 patients. So yes, there are patients who kind of blur between type 1 versus type 2. And your question of whether type 2s eventually become type 1, in a simplistic way, I could say yes, because the truth is, initial stages, your pancreas compensates for that resistance by making more insulin. But there is a common and well-evidenced belief that beta cells, which is the cells that make insulin, eventually get fatigued, and you can end up becoming incapable of making insulin. And therefore, yes, type 2 can evolve to become completely dependent on insulin. And it doesn't matter whether you're on one different insulin or two different insulin. This distinction between type 1, type 2 is actually not as critical. What is critical is what are the reversible factors that you can do, and insulin requirement comes into the pot even for type 2 at some stage in life. I hope it answers some of that question.
Thank you. The next question is from Elaine Proctor. What is the best way to ask for a change in medication, and what should you ask for?
I knew this was coming. Elaine, nice to see you here. So I think at every contact when people have their diabetes reviews, it's very reasonable for us to be cited, you to drive, in fact, to say, I appreciate my cardiovascular risk. What are all the things that we've done to mitigate the risk? Am I on the most optimum combination? And of course, I will not be able to spell out who needs what without the specifics, but it's very much within your gift as part of that consultation, even if we were to rigidly hold you to A, B, C, D, E, to take a pause and say, can I have the assurance that all possible evidence therapies are what I'm on? And I see it in practice. Sometimes you're so tempted to not rock a boat that's sailing smoothly because every change also comes with risk. So even if I've made it look as if this is great, it doesn't mean existing therapies are hopeless. It's about balancing what is the immediate need, what is the goal of treatment. And the short answer is, if you could say that, am I on the most evidence-based optimal treatment for my needs, not just for my sugar, but also my cardiac risk or my renal risk, would be a good way to remind people that we are not overlooking that. Thank you.
And the next question is from Roger Lloyd. You've concentrated on type 2 diabetics as the subject of the talk. To what extent do the same issues apply to type 1 and brittle diabetic?
Okay, cardiovascular risk is very much exactly the same. So there is that risk. Of course, because type 1s typically are early onset, they have the protection of younger age and everything else that keeps their cardiovascular risk until a bit later in life. Whereas type 2s, at least 10, 20 years ago, when they came at 50s and 60s, they had the disadvantage that their age was also catching up. The blood vessels were also getting stiff. So admittedly, today was about the majority diabetes because at a public level, that had far more impact and relevance. And one of these days, I'm very happy to come back, or my colleagues can, to talk about specifics pertaining to type 1, within which brittle is a specific small subset. But the headline that diabetes equals vascular risk is true, whether it's type 1 or not, but it's far more amplified in the multifactorial risky cohort, which is by definition higher at the older age group.
Thank you. The next question is from Dave, a seasonal question. What would you suggest for a Christmas meal for a type 2 diabetic recovering from a heart attack?
Oh, how much I wish I had the dietitian here. You know, you're not recording this, are you? Have a good Christmas. Enjoy a meal. I often say, go and have an extra walk, go and have an extra run or an extra lap in swimming. But we have to have a life as well. You didn't hear me say that. Of course, in moderation, go have what you normally have, but be cited to the fact that you compensate for it. It's a net energy equation. You want to eat more, go ahead, go and do 2 extra laps. I have no problems. But I'm sorry, I'm not going to give you a straight answer on your menu choice, but I hope I've conveyed the fact that we also have to have a life, be sensible, be moderate, and compensate for it.
Thank you. I think we've just got time for 2 more questions. Nicola Woodhouse, how do we get those people on lower income bands and others to move away from highly processed foods?
Duncan.
Yeah, shall I take this one? And again, I think some of this is understanding why there is a difference in diet between different groups and different parts of the population. I mean, essentially, people eat highly processed foods or fast food takeaways or similar because it's cheap and convenient. So it's what we can do to try and break that cycle. Essentially, there's a push and pull factor then. So if people use it because people go here because it's quicker and easy to prepare and easy to access, then one of the things we need to be looking at is have we got the right food environment, and is it a healthy food environment? So again, you see a higher prevalence of hot food takeaways and similar in more deprived areas, and that contributes to it because there's more availability of unhealthy foods and less availability of healthy foods. So there's, going back to my 4-quadrant model, thinking about the wider determinants and the role of the planning and planning policy and similar in there. So that's one end. And then the other option is the other set of factors to encourage for healthier eating. Some of that is to do with again, calorie labeling and similar. Again, interventions like that are more often taken up by people in more affluent environments. Some of it is working with schools and supporting earlier education, and again using that to influence how families eat. And some of it is essentially that sort of promotion of wider living circumstances and supporting people to have to find to break the cycle of the inequality and to through sort of education and sort of better employment and similar. So there's a range of things in there. Like most challenges, it's not in public health, it's not a single solution, but actually by working across all of those 4 quadrants, you can start to address some of those inequalities, start to understand how to influence, some of the sort of cultural views and the views of foods that, are sort of different within different groups or different parts of society or by deprivation or what have you, start to promote what good healthy eating looks like, start to address that food environment, and also, look at what education we can provide when people are in hospital, and again, how to support people to understand what a healthy food environment looks like.
Thank you, Duncan. So one final question from Alison. Do pancreatic cysts contribute to insulin resistance?
I don't know. I don't think so. I don't quite know if you mean pancreatic cysts, or because pancreatic cysts are quite rare conditions and they certainly have no direct link to insulin resistance. So the word insulin resistance is the inability of insulin to shift the glucose from blood to the cell. And that is usually the liver, the muscle, and other areas where the glucose is taken up. So I don't think a pancreatic cyst is a direct contributor, no. It's the visceral fat.
That's the end of the questions. Thank you.
Excellent. Thanks very much. Thank you to everybody who's joined. Thank you to Bhaskar and to Duncan. Thank you for Sue for managing us and reading out the questions. As I said at the start, this is the first of a series of talks. So do watch out for adverts in social media and on the Trust's website, advertising new ones. Don't know what the topics are yet, but other than that, there's just one final call for more research from Francis, which now that we're a university foundation trust, we have routes to maybe do some of that, which will be interesting. And as Bhaskar said, he'll take that to the appropriate place. So thank you all very much for attending, and can I take this opportunity to wish you all a very Merry Christmas and festive season. Take care. Bye.
Thank you, everyone.